I'd like to thank the organizers of the conference and to lay out one thing as clearly as I can. And that is, you have here a number of social scientists who are very, very pro basic science. And there's this very silly division in social science between camps, one of which I would call the Luddite camp. That's the camp that feels that the basic sciences neglect the social sciences and there should be more attention turned to social science, and it's a bunch of complaining, etc. Our own view, and I think I speak for several anthropologists here, whether they're physicians or not, is that we certainly feel that resources should go into the social sciences relevant to medicine and health and well-being. The issue, however, is not that we're being snubbed. It's that in order to benefit fully from the discoveries in the laboratory, we're going to need to have a much broader take on these problems. For example, Fotis Kafatos has mentioned the signal events of the last year for many of us, regardless of how far we work from the lab, has been the discovery of the genome of both the organism that causes malaria and therefore drains so much, I can't say wealth because it's something more akin to draining an absence of misery, drains so much from the subcontinent in Africa and also from Haiti where I work. But in order to move from the fruits of that specialization, and Reiner said, much benefit is gained from focusing down and blotting out the rest of the world and focusing on the laboratory. That's what we want scientists to do in order to make the discoveries that become tools for diagnosis, treatment, and eradication. That's what we want you to do, those of you who are scientists. It's not that scientists should become medical anthropologists or social workers. That's not our argument. Our argument is in order to use these discoveries in an effective manner, we have to then re-socialize the epidemics in question and have a strategy, which I have rather openly called a social justice strategy, in order to make these tools used where they're needed most. And I will try to do a brief survey from Haiti and Peru, looking at a couple of diseases to just simply show why we want you to keep doing what you're doing, but allow us to re-socialize a number of epidemics. I was going to also talk about Russia, but Laurie Garrett is here, and I think that she's better placed to do this than I am, but I think it's a very similar argument. This is the valley that I came from, and I've been working here for 20 years, and on a cold day in Heidelberg, it might not look too unappealing. However, to the people who live there, it's very unappealing because it was created by a hydroelectric dam, which then forced the peasants out of the valley and up into the hills, overnight, in fact, amazingly enough. And I've written about this in other works, and I'm not going to discuss it here, but literally the day the water rose is the day that the population left this valley, amazingly. Because then, of course, this was built through a transnational process, and I'll be talking about transnational epidemics. So this is, government, big development aid, which displaced this population, immiserating it, and then putting it at risk for the epidemics that I will discuss. And these are the hills into which they were driven, and this is the kind of conditions in which they live now. Now, if this was Brazil, you'd then know why it was that they had Trypanosoma cruzi infection. It isn't Brazil, so that isn't the infections that they have. But this is very much related to why they have the infections and deaths that they do have. This, by the way, is what Haitians call indecent poverty, which would, of course, suggest that there's such a thing as decent poverty. And they'd be very happy to describe it to you. And were you an anthropologist, you'd be listening to them at great length because they love talking about indecent poverty. But I'm going to speak more as a physician anthropologist who sees people in our clinic. And the numbers are astounding and terrible. One of the reasons I haven't been in Geneva very much recently, I'll say to my colleague and boss, Carlos, is because the number of patients we've seen over the last year has more than quadrupled in our clinic, and that's just in the clinic. And so this is what it looks like every morning. But when these things happen, they have a history, and you have to re-socialize, as Didier Fassin does in his work, re-socialize the history behind what's going on. Why, for example, would polio, declared eradicated in the Western hemisphere over a decade ago, why would it resurface on this island? And there's always an answer to that, and that involves this resocialization process. Now, I'm not going to go into much detail, but one of the reasons that polio resurfaced there is, of course, because people weren't vaccinated. Or if you look at a measles epidemic in the United States, it's because children weren't vaccinated. And there, on the other extreme, were a number of families, parents, saying, well, I don't want my child to be vaccinated because I understand there are side effects. I go onto the web, I surf the web and find these things about my children. On the exact other end of the spectrum, where there are no webs and there is no computer, again, it's failure to vaccinate. So again, this is the political economy of affliction, but we're talking about tens of thousands of cases on one end and one or two cases that then are able to affect unvaccinated children. But let me go to the question of HIV directly so that we can focus these grand comments about the social forces that sculpt epidemics. We can focus them on specific epidemics. In Haiti, simple epidemiological fact. Haiti has an HIV epidemic that came from North America. That means that molecular epidemiology should show that the clades of the virus in Haiti are the same as those in the United States, which they did do. Now, interestingly enough, some of you know that a very different proposition was advanced back in the early 80s when it was a mystery as to why Haitians had HIV. It was said, well, it's an African disease. There are lots of Haitians in Africa. It came to Europe and Haiti through that connection. Well, that wasn't true at all. A much less appealing reality was in fact true. That steep grades of social inequality led HIV to Haiti from Americans through sex tourism. Now, but that doesn't make a very nice story for the Americans to tell, so they told another one, and this was in the popular press. And when I was a grad student in anthropology, I wrote a book about this topic. But that is also the reason that rates of infection for HIV were maybe 10 times higher in urban Haiti than in rural Haiti, where I work. However, when the coup of 1991, a military coup against the democratically elected government happened, tens of thousands of people went to the high seas and became refugees, but hundreds of thousands became internal refugees. And that means many things, but I'm going to focus on the epidemiology of that, which is people came from the urban slums where HIV prevalence is high back to the rural areas where they were diagnosed in our clinic. Now, I mentioned polio, I mentioned tuberculosis and HIV. Let me mention some more things. And this is enough just to mention that Haiti is the poorest country in the Western Hemisphere. If you want these slides or copies of these slides, I can give them to you. It is the only country in Latin America with a declining life expectancy. And so the epidemiologic pattern seen there is very similar to the epidemiology that's being registered in certain sub-Saharan African countries. But this has nothing to do with cultural ties between these two places and everything to do with, again, the political economy of affliction. And again, that is unappealing, it would seem, to many of our colleagues in the social sciences relevant to medicine, particularly in anthropology, which is all too often focused on cultural minutiae instead of on the political economy of affliction. Now, let me get back to this example of equity. Why would you want to use antiretrovirals, here called ARVs, in a place like Haiti, where there's so many other problems? And here are some answers that I'll just give. But let me just point out what has happened as the international community has stalled over the last 10 years to do something effective in these countries most afflicted. First of all, tuberculosis has been replaced by HIV as the leading infectious cause of young adult death. And then the numbers will be gone over by others and are in your handout. But one of the answers is, of course, the reason to take this on aggressively, both as a prevention and therapeutic intervention, is because it's already too late to only count on prevention. We don't have reliable prevention because you guys, the scientists, haven't given us a vaccine yet. A vaccine is one way of getting around gender inequality and poverty, which are the leading cofactors of HIV transmission, gender inequality and poverty. However, condoms, male condoms, do not get around that problem. So we don't have an effective vaccine. I remember the bumper stickers in the United States that said, education is the only vaccine. Well, unfortunately, that makes a great slogan, bumper stickers. Do they have those in Europe? They're pretty awful things. In any case, it's a great sticker, but it's wrong. It's not true. Education is effective when people do not live in such squalor where their agency, as social scientists would say, is constrained to the point that they cannot use information in order to protect themselves. This is a curve that maybe other colleagues will use. The impact of this one virus has been astounding and will be even worse in the next 5 years unless a very radical interventions are made. Meanwhile, back in the United States and much of Europe and Japan and Australia, this is a very similar looking curve, but it is not a curve in decreased life expectancy. It's a curve in decreased mortality among those already living with HIV. So that's the reason to at least think about using these agents in places like Haiti or Sub-Saharan Africa. They're effective. They stop people from dying. Now, why wouldn't we? Two reasons. One already mentioned by Reiner, which is lack of infrastructure, and another is that the cost of drugs are prohibitive. First question, what sort of infrastructure are we talking about? Are we talking about building a virology lab in rural Haiti? No, we're not. We're not talking about that kind of infrastructure. And number two, cost of drugs prohibitive, but at my last check, it was not God who said, indinavir shall cost $30 a gram, but rather humans who did that. Therefore, one would assume that humans may be able to have some say in controlling pricing of drugs. I'm not sure. It could be God, because the pharmaceutical industry does seem to have God-like powers. But I still believe as a social scientist that it's not God, that it's humans who do this. Now, the situation we're in now, and one against, I want to again pay tribute to Carlos Morel, but a number of serious, real scientists have spent a lot of time worrying about what I'm about to discuss, which is right now we're in a situation where we have transnational inequalities so grotesque, obscene, Reiner said, that we have research done by affluent first world universities and research centers in third world settings where they're using first world diagnostics but third world therapeutics. And that has been the commentary of enormous numbers of poor people in the places I work, Haiti and Peru. In Africa, it's even more resounding, this critique of us, the policymakers and scientists. And I think having groups like yours and like TDR avoid political chicanery and saying, look, we have to take on these social inequalities, even if we are molecular epidemiologists, molecular biologists. I think that's been a very important development in science. Now let me just skip through this. Just want a couple of images, and I would add that these images of my patients, our patients have asked, please use our images and our names when you go to these conferences, because we don't get invited to the conferences. And I've had a number of exchanges with medical journals said we can't publish pictures of patients without their permission. I write back, the patients have asked that their images be used and their names. So again, this incredible concern over international ethics is not yet seeped into a concern with the distribution of the fruits of science. Much more interested in developing ethical review boards and spending time protecting our own institutions than we are at developing more equitable matters of distributing it. This is just our own. The problem here, and this is to skip over to HIV, TB, the problem in our patients with HIV was that they had tuberculosis. That's what I would call, for those of you interested in the clinical part, poor person's PCP, pneumocystis carinii pneumonia, is TB, easy to treat. We started treating patients, and our infrastructure was not new laboratories, although we would love to have them because we're not Luddites. Our infrastructure was community health workers. What the hell is that? I don't know what it's done. I don't know. I'd have to ask Luis. In any case, in transiting over to, not to some, I don't even know where that picture was taken. It's not on my computer. It is not Haiti, let us say. Before I transit away from HIV, I was talking about equity initiatives. Obviously, vaccines, the fruits of your labor, those of you who are scientists, and the fruits of your labor, those of you who are bringing into relief the silly debates that go on in international health. They're absolutely absurd. Again, I mentioned one, can we publish the photograph of a patient? The patients are saying, please publish our photograph so that you'll stop killing us. That's what they tell me. Then I have to find a polite way to put that into a scholarly journal. Because, of course, you can't possibly say something like that, even though that's what the patients are saying. The people who are at risk are saying things rather crudely. You could never get that into Science or a medical journal. You'd have to water it down and transmogrify it and have someone edit it 15 times, and then maybe you could get it in there. In any case, the issue that I'm making around using HIV is that social inequalities sculpt the epidemics. That is, they determine who's at risk and who's not at risk. They also impact the degree to which our existing prevention efforts will be effective. Right now, we rely on male condoms and information education campaigns, which are effective among Thai soldiers, which are effective among middle-class people in San Francisco. They are not effective when the main forces conspiring to increase risk are gender inequality and poverty, not ignorance. So you can spend a lot of time. Am I back up and running? Almost. You can spend a lot of time developing new culturally appropriate tools to prevent HIV, but if the problem is not ignorance, but rather social conditions, what will be the impact of these interventions in preventing HIV? And our answer is, we do it anyway, but the impact is very limited. As as someone said to me shortly before she died from HIV in an interview which we taped, if you want to stop HIV in Haiti, give women jobs. Try getting that into a scientific journal. Now, I was hoping to continue with the example from tuberculosis. I don't know if chances are good or bad or. In any case, let me do it without props. You just said they're not good? No. Okay, so I'm basically out of luck.
Have to sort out this computer.
Okay, as we say in my country, I'm shit out of luck. Well, in any case, let me run through the. All right, so HIV, the big issues on the agenda from our side, which is clinician side, from the social scientist research side, are still looking to the basic science community for new therapeutics and for new preventive. That's still very much what we were hoping you're going to do, those of you who work in the lab, is give us better molecules and give us a vaccine so that while we're having a hard time skirting poverty and gender inequality, the least we can do is link our research to services to the poor. And I would call this an attempt, it's a very late attempt, to remediate inequalities of access so that social inequalities are not embodied as differential outcome. Now, I know that sounds like a whole lot of jargon, but I really mean it quite specifically. Remediating inequalities of access in order to prevent social inequalities from being embodied as differential outcomes. And when I say differential outcomes, I mean differential risk and also differential risk for bad outcomes among those already affected by HIV. The story for tuberculosis is not too different in some ways and is very different in others. One, mode of transmission, as I've already warned you, is by cough. Number two, and it's not a sexually transmitted disease. Number two, we don't have new molecules. For 40 years, there's been no new anti-tuberculosis agent discovered. The drugs called the fluoroquinolone were accidentally discovered to be effective against the organism, Mycobacterium tuberculosis, also recently sequenced, thank God. I mentioned God 3 times today, mostly to swear, though, at the pharmaceutical industry, and also then, when I say swear at, I'll get back to that because I'm not really swearing at the pharmaceutical industry. On the contrary, I think we should be sociological about what it is they do, can do, and do. Now, back to tuberculosis. No new therapeutic for the leading killer of young adults, infectious killer in the world in 40 years. I mean, that's absurd. That means that your efforts in the laboratory are being perverted in order to make sure that people like me can have more hair or be more virile or something. The budget for research on tuberculosis about 5 years ago from the NIH was about the exact same amount as the budget for Viagra for the U.S. military. That's public money going to, it was about between $40 and $50 million. And I see Laurie taking notes. I can get the documentation on that. When Laurie writes a book, at least a third of it is going to be footnotes. Now, and I say that full of praise because I think that's the appropriate distribution of documentation to commentary. Now, I am not doing this here. I'm just sort of trying to stall in the hopes that my slides are going to come back, but I'm not going to have time to keep stalling. So for TB, the story is even worse in terms of therapeutics. So that means that the majority of these deaths are not due to a lack of, but the majority of these deaths are not due to a lack of new therapeutics. They're due to a lack of putting in place the basic health infrastructure that can detect and treat and bring to cure about 90% of all TB patients in the world. They don't need new tools. Now, unfortunately, the Luddite branch of our international health world, of which I'm part of the international health world, but not the Luddite branch, then said, well, we don't need new research. We don't need it. And this was a public debate, some of you will remember, between people who I will not name and others I will not name, but it was played out in the pages of Science and in various important journals. All right? A group who would actually say, stop research on TB. That's ridiculous. We need new therapeutics. The diagnostics are 100 years old. They were invented in this country in 1880. That's why everyone still calls it Bacille de Koch, or however you say that in German, which is unpronounceable to us Francophone and Anglophones. Thank you. Thank you. I'm going to speed this up now. But you guys should have a lot of sympathy for me, because that was pretty good that I could manage to pull that off. Thank you.
I think you're even much better without the slide.
Oh, thank you. I get much saucier, that's for sure. So, now, anyway, the missing infrastructure for us was community health workers. And we said this in the international community, please don't deny us access to the fruits of science, in this case, lab work and medications, because you say we don't have infrastructure. It's true we don't have infrastructure, we don't have labs, but we have people. We have 70% unemployment. They want to do the work of an outreach worker, and this is a picture of an outreach worker giving directly observed therapy. Now, let me just, before I show you the next image, talk about silly debates. This one I'm not going to blame on social science. I have gone to conferences where people said, you can't use antiretrovirals in Southern Africa because there's too much stigma around AIDS. And we say, there's stigma around AIDS because you're telling people it's a death sentence. Of course it's stigmatized. Cancer in the 50s in Germany. Read about stigma and cancer. They wouldn't even, in Germany in the 50s or the United States, they would not tell a patient that she or he had cancer. It was too stigmatized. So I let the patients talk. Again, this is Samuel. This is the day I first saw him in the clinic in Haiti, and a picture taken recently, a couple years later, of him with his son. And he talked about stigma. We interviewed him about stigma, and you can read it. He didn't use the word stigma, but everything you need to know about what he has to say is right there. He says, before I was on therapy, my children were ashamed to be seen with me, and now I can go out of the house and and I can work again. I mean, this is, I think, much more reliable than having experts talk about stigma and why that's a barrier to using the fruits of your work, that is science. Now, I'm going to have to skip ahead. I was going to talk about mother-to-child transmission, and then I was going to scare you with this image since I'm also coughing, and let me just show you how crazy it is to not re-socialize, just with numbers. Now, this is about tuberculosis, okay? So all these red bars are about TB, but we're in the era of HIV, okay? What is the impact of one organism on the other? Now, first is smear-positive reported cases. Now, that reporting system has two ends to it. In other words, WHO and PAHO have told the Haitians they're only interested in smear-positive cases, which is too bad because about half of them are smear-negative. And the other end is, what does this reflect? And that's called reporting capacity. So the less strong the public health infrastructure, the less capacity to report. And of course, as you all know, the public health capacity of Haiti has declined, not increased. So they reported total number of cases of under 10,000. And then if you go into a slum in Port-au-Prince and do actual prevalence and incidence work, you can estimate that they're missing the vast majority of cases. And here's the data on which this was. The Partners in Health is called Zami La Santé. And this is a real incidence study. That is, you go to a community and you go and do a survey with community health workers. That's what you find. And then Cité Soleil, a real prevalence study done by active case finding, which means house to house. So completely different numbers you'd get. And this is probably scaring the basic scientists because they'll be saying, gee, that's a wide margin of error. And we agree. Then I was going to present a case of transnational tuberculosis, someone who died in Boston of TB acquired in Peru. Now, transnational, why don't we talk that way all the time? Well, we should. Look at what fraction of cases in Massachusetts of tuberculosis are among the foreign-born. And there's a study from Hamburg, Germany, which shows that all drug-resistant cases, 90% of them, were from foreign-born people. And then I actually made with my colleagues in Boston, we made a slide from Hamburg going out to all the countries with arrows in it to show how transnational tuberculosis in Germany was, but I couldn't find it this morning. And this is the place that active case finding would lead you to from a teaching hospital in Boston where this man died. He was an American citizen and worked with us. This is how we discovered this epidemic in Lima. We went to the shantytown where he worked, and every red dot represented, 1997 note, a case of active pulmonary untreated multi-drug resistant tuberculosis, women like that. And then we began using the fruits of modern science to find out how this epidemic came to be. That means, as was mentioned already by our leaders really, that means teams of people with epidemiologists, community health workers, people in the lab doing the basic science using molecular epidemiology. And this is, by the way, one family in which every single adult has or has died of multi-drug resistant tuberculosis in a country in which we were told in which TB was perfectly under control. Not only by the Peruvians, may I say. Now, this is the same map we made for Hamburg, but it's from Peru, showing that these are not local epidemics. They're always transnational epidemics. And this is a report from the WHO in 1995. Now, I'm not going to spend a lot of time, but I just want to show why we need to avoid this Luddite approach. We've already got this under control. We don't need any more research. Wrong. We need research to do our work, regardless of our work can do. Now, this is saying that it's raining MDR-TB over Colombia, but Peru, as you can see, it says Peru is being defeated by a model DOTS program. And I know I have to speed this up, but what this is about the high cost of the medications. Again, that's what this debate was about. So it would have been better to have this is from a 1997 publication from the WHO, from a part of the WHO at that time that no longer really exists, which was basically saying don't try to treat this disease in poor countries. Now that turned out to be an error, and because the conventional way of managing this disease was in fact not clinically effective. 5% cure rate, well, that's not very good. And so it may have been a managerial success, but it was a clinical failure. And patients and their families don't care about managerial successes. They care about not dying, reasonably enough. And this is, I'm out of time, aren't I?
We have time since
Well, let me just show you what this is like. What happens, and I think for those of you who are not clinicians but are scientists, what do you think happens when you give people, put in their mouth, directly observed therapy, the wrong drugs? In other words, you're giving them drugs to which they're already resistant. Now, it turns out that if you keep on doing that, the microbe itself will mutate to become resistant to every drug in the cocktail they receive. So the definition of multi-drug resistant tuberculosis is resistant to the two best drugs, and they're isoniazid and rifampin, symbolized here H and R. Long story, you don't want to hear it. But that's what MDR-TB is. Technically, it's only resistance to those drugs. But when we got these patients, they were resistant not to 2 drugs, but to 5 drugs. And that was because bad policy had them be retreated again and again with the same inexpensive drugs. Now, how it works itself on the level of a family, maybe this is an anthropologist's work. This woman is one of the people in that family in which everybody had drug-resistant TB. So, of course, when her husband became sick with multi-drug-resistant TB, it's reasonable to assume that he also has, when he became sick with tuberculosis, and you have proof on your slide, and not in your hand, one hopes, but on your slide, if you have proof that he has tuberculosis, which is still the same diagnostic tool that Koch, how do you say it right in German? Koch. Sorry, you'll forgive me. Actually, I can do it better with a cold, I find. The same diagnostic shows that he has tuberculosis. You'd worry that he had MDR-TB. And so, but no, he was forced to go through the same treatment, and Didier has already seen this. And so, in order to withdraw from treatment, the wrong treatment, and going to the right treatment, they made him sign this paper, which through the marvels of, someone says something about Bill Gates, the marvels of scanning, we have an image of what, he forgot that he signed this, by the way. We later showed it to him. He said, do you remember this? He said, oh yeah, I forgot all about that. And basically, that means that this patient is reclassified as what kind of patient? What's the word they use? Recalcitrant, much more. Non-compliant, non-adherent. In the United States, they say, not with the program, which I love because that's what they said there in Peru, too. He's not with the program. Well, in fact, he was completely adherent to the wrong drugs. But he was smart enough to know if my wife and my 7 in-laws have MDR-TB, I'm probably going to have it too. So he withdrew. But he was listed and reported as a non-compliant patient. Therefore, he had acquired drug resistance, not primary drug resistance. Now, these so-called untreatable patients, we treated them, and guess what? They weren't untreatable. The cure rate was as high as the cure rate you often get with non-multi-drug resistant TB. And it also it reinforced, anyway, just this is a closing image. This is another child whose name is Joanna, and I'm sorry that I don't have another image of her because she's doing fine. She's doing fine. She had tuberculous peritonitis. That is, she had TB outside of her lungs. And therefore, by current criteria, she doesn't even exist. Let me show you one more image of another young lady who had, you can't even tell she's a lady because she's bald. She doesn't have access to those drugs that grow people's hair. But what she really had was extrapulmonary tuberculosis. So according to some very minimalist criteria, she doesn't have tuberculosis. Because the only people who have tuberculosis are, as I said, those who have smear-positive tuberculosis. But she didn't have TB of the lungs. And if you went a little bit farther and did the diagnostic workup, this is the person inside. That's the real Roselaine after treatment. And that's only 7 months later. Now back to this little girl. She also has, everybody said, oh, she has AIDS. Well, she didn't have AIDS. She didn't have HIV. She had extrapulmonary TB. And let me just say, she spent a year trying to get diagnosed. And she's 10 years old. Okay? That's another reminder that if we had a better vaccine, she wouldn't have gotten sick. If we had better diagnostics, someone would have just done the peritoneal tap much more quickly. When she finally got to us, she came from many hours away. That's the condition she was in when she got there. And fortunately, she's recovered pretty completely. And if I ever get invited back to Germany, then I will show you an image. And I'll close with that then. I think the hope I had was to link the social inequalities not simply to the distribution of the epidemics, but also to the distribution, the unjust distribution of the tools that could do something to take them on. Thank you very much.
So please, the floor is open. I'm sure you have a lot of comments and objections and... Yes, please, the microphone will be given to you.
Robin Weiss, London. Would Paul like to comment a bit further on HIV as the generator of TB? That, as you said in passing, well, TB is not transmitted sexually, but by coughing. But to what extent is HIV exacerbating the world's TB epidemic? Well, maybe Paul Van Helden will cover it this afternoon. But
well, just one. First of all, thank you. I should have underlined that. You're quite correct. You used the word generator. I think that's a very solid one. In the northern countries, in the United States, for example, particularly, HIV was indeed the generator for the major amplification of the epidemics that were noted in a number of our cities. New York, Miami also, San Francisco. All of them had a huge, what were called excess cases However, it's a very different story in places like Haiti and sub-Saharan Africa. There, tuberculosis never went away. So it never was a re-emerging disease. And that's another construct that I think we need to take on sociologically, the idea of emerging and re-emerging diseases. Tuberculosis never went away, so it couldn't really re-emerge. I think Laurie made that point in one of her books. And what it has done instead is to exacerbate an already horrific problem. And the numbers, I mean, South Africa, a relatively affluent country by African standards, can no longer hope to control their tuberculosis epidemic, and I'll give you some numbers, without responding much more aggressively to the HIV epidemic. The numbers are the tuberculosis in the black population never got very low, never much below 200 per 100,000, maybe even 300. But overall, thank you, national averages now, according to the Medical Research Council, exceed 500 per 100,000, which is, you know, as bad as the poorest countries in Africa. We have people here from Mali who may know the numbers from Mali, but I can tell you that in Haiti, that's about what the level is in Haiti, as you could see. And South Africa has a GNP or a PNB or a PIB, whatever you want to call it, that's 10 times Haiti's. So 10 times less poor than Haiti, still a poor country and a very inegalitarian one. But the motor force, the generator, is HIV. In Zambia, someone from the TDR recently showed a slide at a conference in Seattle, this is Mark, of the impact of HIV on our ability to diagnose TB, because as I mentioned, the diagnostics we use now are 100 years old. They're based on smear microscopy, which is insensitive even before HIV came along, and now it's estimated that the majority of all cases in Zambia are smear negative, which means the diagnostic that we're touting as the only diagnostic needed, that of course I disagree with, but that our officials are saying that all you need is smear microscopy, now they're even less effective and less sensitive. So I think it's very much the generator.
Thank you very much. Yes, please identify yourself and then goes your question.
Yeah, I'm Paul van Helden from Cape Town, South Africa. Interested to hear that you are quoting South Africa so frequently. You're quite correct, of course, that South Africa may be regarded as a wealthy African nation. However, in the context of Western Europe, of course, we're still extremely poor. And I was interested in your comments about ethics recently. I'm particularly attached to this subject since I am unfortunately chairman of our ethics committee at my university.
You have my sympathies.
Thank you very much. Now, just by way of an anecdote, I would like to elicit some comment from you. I was recently part of an effort to attract some NIH funding for TB HIV work. And the US partner said that their ethics committee would insist that any patients that were diagnosed early, in the event of our research providing an early diagnostic test, should be placed on therapy for the rest of their life or as long as they needed it, whether it be HIV or TB. And I said, well, that would not be possible since the official government policy in South Africa said no anti-HIV drugs available, of course. I said, and who was going to pay for that? And this US-based person said, well, the state, of course, must pay for the drugs. Now, I'll show some statistics and some facts and figures in my talk a little later today. We simply can't pay for it. And I then had to withdraw from that application to the NIH because we certainly couldn't guarantee that. And this is a major, major problem. So your comments on that, first of all.
Well, I'm going to make some sociological comments on that, if you'll bear with me. First of all, the reason that they would say that is not, I shouldn't say they, I sound like some sort of paranoiac, but I can assure you that those concerns are quite novel within that setting, because the NIH, which is probably the largest funder of medical research in the world, as far as I know it is, it is about more than 10 times larger than Institut Pasteur, according to my friends at Institut Pasteur. But as he added, at least in our cafeteria, we don't weigh the salad, which I thought was a great French comment. Sorry. In any case,
You want to comment on this?
In any case, NIH was quite willing to pay for research in which they were first world diagnostics. What do I mean by first world diagnostics? Well, I mean molecular assays of viral load over time. That's a first world diagnostic. But there was third world therapeutics, no antiretrovirals, and not even assurance of good palliative care. Now, I don't want to pick on any one research project, but this was a multinational research project funded by U.S. capital, and I'll get back to capital in a second, and involved a number of course, African colleagues, and it went through about 1 million IRBs. 1 million ethical review trials, and passed, of course, because there's not a social justice component to medical ethics yet. Medical ethics finds social justice talk very embarrassing. They're very embarrassed and look away, and they don't. I've been on the ethics committee many times, and when you try to socialize ethics and say, well, this is also about social inequality, it's regarded as extraneous. Now, unfortunately, it's not regarded as extraneous by the Africans, who are I'm not talking about your country, but other countries, although I will return to your country in a second if I may. I'd like to go there more often, in fact. But the African critics of this research were very vocal, and now that some of them had access to the internet, they made those views very widely circulated within the space of 24 hours after a publication in New England Journal of Medicine, for example. I was in rural Haiti receiving a barrage of email about how this research project was just tantamount to Tuskegee. And I know you know the history of that. Back to South Africa, poor by European standards. Well, you know, it's the 10 years ago it was the 28th country. The per capita income of whites was $20,000, and for Africans, $800. And now those are both higher, but the outcome gap, the income gap, is widening, not getting smaller in South Africa. And that is a social gap between, and I'll let you and Didier speak about that particular place. But first of all, about the specific critique, everyone diagnosed early should be on antiretrovirals or anti-TB drugs for the rest of their lives. That just shows that this is not sincere, because any infectious disease specialist would say, but you don't need anti-tuberculosis therapy for the rest of your life. It's a 6-month course of treatment. So there goes one part of it. Antiretrovirals should be reserved for those with advanced HIV disease. So early detection would lead you down a very different clinical pathway if indeed the welfare of the research subject was the primary concern. And maybe it would be 10 years before that person was offered antiretrovirals. So their skittishness, and I don't know if that's a transnational word, their skittishness about this has been imposed on them by critiques from well beyond the borders of our institutes, which, by the way, I think are great and support very strongly. What I'm saying is not a critique of NIH or a critique of a local response, but really the need, again, as this panel tries to argue, to re-socialize medical and research ethics more broadly so that we can know what the arguments are about. The arguments are about social inequalities. That's what they're really about. They're about poverty so close by wealth. And that's why you could have South Africa become the pioneer in organ transplants. It's because in spite of all this poverty, there's also vast wealth in these giant hospitals with research capacity. And you know, in Brazil, I've heard people call Brazil Belindia because it's Belgium and India in one country. And these are not things that we scientists talk about very easily. And I think we have to if we want to understand how to do good and very necessary research, such as the type that I'm sure your group proposed. If we don't, we're just going to be left with doing research only on the problems of the affluent. And then we'll never have the vaccines and diagnostics and therapeutics that we need to take on the plagues of the poor.
Thank you. We have, now we have to go from left to right if you like. I didn't see who left their arm first. So, Hans, please.
Just brief on the topic, but this problem with South Africa is a real issue in all research projects. But WHO has basically changed the requirements. You write nowadays, and also the European Union, you write now the best available measures have to be taken. And that leaves it open that the best available, as we have just heard for tuberculosis, is a short-time treatment, which can be affordable, even by the agency who funds that research. And for HIV, there's probably other things which have to be done. But the real crucial point is if those measures are taken too high, then we are inhibitive. And that happened actually very clearly in the US with the opening gap in the early days of antiretroviral therapy when new drugs came up, but the FDA didn't allow them with very high safety margins, and the activists threatened to storm the White House if they wouldn't be available. And I think this is the spirit which we have to not directly use, but which we have to keep in mind, that things become affordable. Otherwise, we inhibit our own progress.
Dr. Van Allen, do you want to comment, or?
From my perspective, actually, what really is needed is a great deal more, I almost want to use the word activism about ethics committees, because I really think that each ethics committee seems to be hell-bent on out-ethicizing the next one. And if we don't address these issues directly head-on, the people on those ethics committees who are not in this room today are not going to know the sentiments of the people who are out there.
Can I just give a response to that? You know, and I will be very brief because I want to hear from others. But for example, I wanted at Harvard to actually just treat patients with standard of care, okay, in Haiti. I was asked to go through the ethical review board. I wanted to say, are you crazy? This is not research. This is remediating inequalities of access to care. They said, well, you're a Harvard professor. So I mean, that's how crazy that, you know, this is a legal thing. It's protecting the institutions. It is not promoting research, and it's not protecting. It's often not. It sometimes is, but it's often not protecting the rights of the vulnerable. It's to protect very often the institutions.
Thank you. We go left from right, so please, lady.
First, one quick comment. I think the Human Genome Project in the United States, which had built into it this massive component for hiring ethicists, unprecedented in the history of American science, overemployed ethicists, and that's part of our problem right now. But the question I have for you, Paul, is 2 years ago you were spearheading a very, very strong and very critical attack on WHO's DOTS program and calling for what you were calling DOTS Plus.
Yeah.
Where does that stand today, and does DOTS Plus solve the problem?
Can you explain what it is?
Yeah, well, first of all, DOTS means directly observed therapy, comma, short course, okay? And we were pointing out that short course chemotherapy is based on the two drugs to which all of our patients with MDR-TB, and there's a huge epidemic, by the way, of MDR-TB in a European country with about 13 countries bordering it, and that is Russia. And it's enormous. And, you know, I hope there's time to discuss it. And so if you give those patients short-course chemotherapy, not only do they fail to get better, they get worse because there's drug toxicities, and also they acquire resistance to the other drugs that are not curative, but they're helpful used in these schemes. So we said, look, the reason we came up with this silly term, DOTS Plus, was to placate our colleagues in the WHO. You know, we said, we love DOTS. DOTS is great, DOTS is good, let us thank him for our food. We love, this is a great thing, but we have to take care of patients who will not respond. And again, in the prisons of Siberia where I work, that's the majority of the patients. It's not gonna work. And so, yes, I can tell you that it's been successful. In fact, one of the documents we brought to share with you was our efforts, and you know, again, this was thanks to a lot of people inside the WHO as well, including people from TDR who are not so ideological as some of the international health people, who said, well, you know, it's important for all sorts of reasons that we develop new strategies. So we call it DOTS Plus because it added new drugs, and it begged for new diagnostics, and it begged for new therapeutics. So this expansion, which is a very broad movement now, is actively calling for expanding DOTS to include basic science research also. If you see our document, it says we aren't going to go anywhere without new diagnostics and new therapeutics. And at TDR, for example, in the diagnostics subgroup or whatever, I can't ever figure out the... I guess if you directed a Brazilian organization about 10 times bigger than TDR, you're not intimidated by all the organograms. But the diagnostic, what is it called, unit?
Well, that's called the committee diagnostics.
The diagnostics people, they are now taking on TB diagnostics inside TDR. So we've grabbed tuberculosis and made it a TDR disease in order to get, help move forward that the basic science agenda. So yes, I think it has worked, Lori. I think a lot of movement. And we also have shown that it is possible to bring a lot more resources to TB control and to TB basic science resources by talking about MDR-TB rather than pretending it would go away.
Thanks, Paul. Now, yes, Rob.
Yeah, I'd just like to make two comments. I think the first is there's been some, maybe some righteous comments about some of the excesses of ethical review boards, but I think we should be careful not to take those comments to minimize the value of appropriate ethical review of studies, and particularly the need to apply better quality and standards of ethical review in the developing countries where a lot of this work is being carried out, and to enhance the capacity of those countries to review appropriately the ethical issues associated with studies that are being done in that country. So I just wanted to present that as a slight balance to some of the comments that have been going on. The other thing is just for information. The comment was made about a requirement of antiretroviral therapy being made in perpetuity to a US-sponsored study in a developing country. There are now some examples of countries also requesting that from within the country themselves. So it's an issue that is possibly going to become broader than just a US-based requirement of US-funded studies. It might be something that is grabbed hold of by certain people and or certain countries and put in as a qualification for research related to any disease which could be co-infected with HIV and in developing countries. So that's just for information.
Thanks, Rob, for the information. The gentleman here in the front.
Giuseppe Testa, Max Planck Institute in Dresden. I would like to come back to the case of the smear test that you showed us, where smear positives clearly are a minority of all cases, and yet this is what informs policy, if I understand correctly. So the very naive view would hold that scientific facts should at least constitute the basis to inform policy. So this is a clear example where we are having a scientific fact, which is the knowledge that the majority of TB cases are actually smear negative. And yet this knowledge is not being translated, that does not make it through to become policy. So what's your feeling? Where are we losing the chain? Is it a lack of money? Is it failure to transmit knowledge to the appropriate people at the appropriate times? At which steps are we losing this chain? Thank you.
You're absolutely right. That was my point, with two qualifications. One is I was talking about in HIV co-infected people, the smear test becomes less reliable. And the number from Zambia, which came from my colleague at the TDR, showed that the majority were not detectable using smear microscopy. In children also, that's the case. If you have children, you know that you can't say to a 5-year-old, cough into a cup and give me some sputum. They're very non-compliant, children, in general. I don't know why that is. They're also very short. And they have legume anorexia. They won't eat their vegetables. Anyway, but the problem is, in my view, again, the last time I got to talk about this, interestingly enough, it was at Ringberg Castle, because Max Planck was having a let's stand back and look at sociology of science. And it's that sort of question you've asked, in my view, a sociology of science. How does effective, clear scientific data become transformed into policy? And we all know that is, in the United States, for example, a congressman will say, well, I want more money for polio. My aunt had polio. And those of us in the supplicant community say, oh, thank God his aunt had polio. And now we can get money for polio research or whatever, vaccination. I mean, some people here are journalists and writers, and they know more about this than I do. But, this is unfortunately classic. All the silliest reasons that are not based on burden of disease and scientific fact are why policy becomes policy. And you're right about this specific question. It was money. It was every other strategy is too important. How can we get? And they even had inside of their own internal discussions. They would have, one of them said, KISS, keep it simple, stupid. In other words, that was the idea, is to have the simplest strategy possible in order, and that was smear microscopy, the same drugs at the same doses, everything standardized, which makes sense managerially. unfortunately, because it is the nature of microbes to become resistant to the drugs we use, there had to be backup strategies. And I think what we need to do as a scientific community, and if I may permit myself to call myself a scientist, is to catch up and to be more involved in policy debates and have less ideological and more scientific, evidence-based discussion. And I think that would involve having all of you involved.
Couldn't agree more, and we'll hear more of this by Carlos after the coffee break. He's going to get into this topic of policy and research and their interaction. I think we have now the left. Now there's this gentleman here, and then, well.
Okay, Bertolt Rutz from the European Patent Office in Munich. I'm relating to the question of Giuseppe. You've touched on several times on the resistancy of microbes, and you said it's important to get new therapeutics, but I think it's maybe even more important to keep the therapeutics effective. So in what terms are you employing teachings from evolutionary studies for more efficient resistancy preventing prescriptions and therapeutics?
I think that's a very critical question, and I feel like we have a robust answer. For example, our group is the only group that is doing what we call DOT-HEART, which means directly observed therapy of antiretrovirals. And we pioneered that in rural Haiti. And the reason we did it is to preserve the utility of the drugs so that acquired resistance would happen much more slowly. And we know that from our long experience, 50 years, 60 years using antituberculous drugs, and that's why another reason in the sociology of why people were so sort of rigid about DOTS is because it did contain the DOT part in addition to the S part. So the best way, and generically speaking, so that this will be interesting to others, the best way to preserve the utility of antimicrobials is to use them correctly. And that means long enough courses and a large enough number of medications often. For example, monotherapy of many infections is not a good idea. Using only bacteriostatic agents instead of bactericidal agents is not a good idea. And short courses or overuse of antibiotics, which again, if I started taking antibiotics for what I have now, you could bet that I am one of the most hypocritical persons you've ever met because I think I have a viral infection. And if I were a 5-year-old in the United States, I would have been rushed off to the hospital to get antibiotics at the wishes of the mother or the father, in the extent that fathers are involved, and not at the wishes of the pediatrician. So prudent use of antibiotics is the way to prevent the emergence of unnecessary acquired resistance. And that's what our group is pushing for, is prudent use of antibiotics.
Brings us back to health service quality.
Michel Glauser from Switzerland, I had exactly the same type of question. And I felt maybe politically incorrect in asking that question, which relates to the misuse of all the antivirals that could be on the market in poor countries. And now that we know that the virus will become resistant within days if the drugs are misused. One, and second, now that we know that one co-infection is possible. It's been described that even if you have a sensitive strain, if you get infected with the resistant strain may take up and be infecting the patient, a new type of infection. So how do you deal with that when you promote the general use of antivirals in poor nations?
See, I don't promote the general use. As I just said in responding to the comment, I don't promote the general use. I promote the prudent use. And let me just remind you that multi-drug resistant HIV, MDR HIV, is already well documented, but it's here in Europe and in the United States that it's documented. And so I think, 2 points that someone from rural Haiti or Africa might make would be, one, there's nothing great about dying of pan-susceptible HIV, and two, MDR HIV cannot be the province of the rich world alone. In other words, only we're allowed to have drug-resistant HIV, they're not. And that is a response from the victims of social inequality. I've heard it a sophisticated commentary on several occasions. So That's first, is I'm not promoting general use. I'm promoting prudent use, which is why we developed this strategy, which is based on DOTS, actually. So here I am praising DOTS. DOTS is great. DOTS is good. Our strategy to treat AIDS is based on DOTS in order to prevent the misuse of antibiotics. Now, here's what's happened, in my view, as an anthropologist, not as a clinician, is that policymakers have said, and sometimes quite openly because I've heard them say it myself, is because we will have the acquisition of drug-resistant virus, we can't use these drugs in poor countries where there's not enough health infrastructure. They say that all the time, right? Everybody who works in this field has heard it. What they have failed to understand about human behavior is that's, families don't take this, as we say in the United States, they don't take this lying down. So when someone in a very poor country has one of these diseases, and they hear from a doctor or someone or a ministry of health, we're too poor to have this diseases. The families don't say, okay, well, that's the end of that. Then they go to the pharmacy and they say, do you have AZT? And the pharmacist says, yes, I do. If every single African capital surveyed years ago, there were antiretrovirals present for sale. So our response, those who would argue that we must have prudent use of these antibiotics, our answer was, well, then we can't use them at all because there's no infrastructure, whereas the poor's answer was, well, we're going to get them anyway. And they did. And they just didn't use them right. They used them every week, skip a week because they didn't have enough money. In Uganda, for example, in a much hailed program, in order to join the program for antiretrovirals, you had to show that you had enough in your bank account to pay for the meds. So in other words, that's letting market logic dictate who has access to care. That, in my view, is much less prudent in terms of preventing resistance than a better social justice strategy. They would say people who need the care most are those who will get it, not those who can pay for it, and we will monitor very closely their therapy with even to DOT. So I think we have to be realistic about what people do. They may be poor, but that doesn't mean they're going to stop looking and expending all of their resources to save the lives of a beloved family member. And that's why I would argue that the best thing we can do is not take a, well, you're too poor to treat approach, which has been the approach taken so far clearly. And instead we should say we're promoting prudent use of these agents in poor settings, and what would we have to do that?
Thank you, Paul. I think we should stop here